Hi, everyone. We'll wait a few minutes to give time for everybody to join. All right, we'll go ahead and get started. Thank you, everyone, for attending today's roundtable, Renegade Research Roundtable. And today our speaker will be Dr. Todd Davenport. Thank you for being here. Thank you for our team at Renegade Research. We have today a portion of our team, Rochelle, Ellie, Michael, Shelley, and Ruhi and Kat. So thank you, everyone, for being here. Just a very quick housekeeping. To get notified about our events, please subscribe to our newsletter. We will have that posted for you shortly. If you are a clinician, please join our clinician Slack channel. You can follow us on X at Renegade Res or Remission Biome. And we have several clinicians roundtables coming up on May 17, Dr. John Houghton. On June 7th, 22nd and 29th, we have a 3-part series with Dr. Afrin on MECFS. And we have a research roundtable on May 23rd, which will be on T-cell dysfunction in MECFS and long COVID with Lisa Selling, Anna Gill, and Roshan Kumar. And please join everyone the Unite to Fight conference on May 15th and 16th, a wonderful event that has been crowdfunded, 2-day online conference with an impressive line of speakers, included Dr. Davenport. So thank you so much for being here, and I'll pass it on to Rochelle.
Hello, so I am Rochelle Sepulveda, and I I work with Renegade Research and have been coordinating with ME Action as part of their Teach ME, Treat ME event. And so that way we can have this webinar also help kind of get you guys to the CME credit for the ME Action has developed in coordination with the Mayo Clinic. And Todd will have some info, have that up for you after just a little bit. But just to start off with, I wanted to talk just a little bit about kind of like the patient experience and why it's so important for clinicians to be aware of MECFS and long COVID, and the idea of like that it's not a hopeless illness. There is a lot of things that we can do to treat the illness, and especially if we can recognize it early in the earlier stages. So in my path, I was actually dealing with some types of neurological symptoms and things since when I was about 8 years old. But it was really not until I was in my 30s that my health had a significant downturn. And I would still blend into the very, very mild category for ME. So the symptoms were not well known and are hard to spot and vague. And my doctor worked quite a bit with me to try to figure out what was going on. And we kind of investigated together and explored various treatments. But he didn't know about MECFS, and the only things that we knew about it were the severe presentations. And I had suggested it a few times to him, but we knew that I wasn't in that state, and we didn't understand about the mild stages at that point. And then 2020 happened in March 2020, and I got COVID. And by the fall of 2020, I was looking into the possibility of wheelchairs because I had no mobility left. And that's when I was connected in with the long COVID community and then the subsequent MECFS community, and started learning about various treatments and recognition and what's the source of a lot of the symptoms that I was experiencing. And that's when I finally had effective treatments for something that had been plaguing me for 15 years. Wasn't until I was severe, or not severe, I still landed in the mild category, but that is very life limiting. And so now I've gotten a reasonably good baseline and function back, but I'm always wondering about what would have happened if my doctor had known about this earlier. And so that is our goal, is to help you guys know all about that earlier. And one of the things I could not have done is to get to the point that I'm at now without the support of my husband, which then brings us to Kim Moy. And she'll talk about the caregiver experience.
Thanks, Rochelle. Yes, my name's Kim Moy, and I've been a caregiver for my husband who has had MECFS for about 30 years. I've been with him for over 20 years, and it's been a roller coaster. Like many others, he was initially misdiagnosed. It took several years to get a correct diagnosis. And then since then, it's been challenging to find medical professionals who have any familiarity with MECFS. And then it's even more challenging to find doctors who can actually treat and address MECFS. And when we do find them, they're like gems. They're precious gems that we really, really treasure. People like Stacy Stevens and Todd Davenport here with the Workwell Foundation, who helped us win disability benefits after my husband took the CPET test that they offer. I'm not alone. There are so many caregivers in the support group that I've been leading for the past 5 years who have great difficulty in finding doctors who are knowledgeable. So I really applaud all of you who are attending this webinar or watching it later for, really getting more informed. I really appreciate and have more hope than ever. My husband's actually severe. He's mostly bedbound, although he's able to do things. He's able to walk on his own, but he's not able to work. Limited ability to interact with our kids. So really very debilitating. So again, I really appreciate a lot of recent efforts, and I have more hope than ever, as devastating as the illness has been on him and our family. It's the creation of this Renegade Research Clinicians Roundtable. It gives me so much hope. I really appreciate this initiative in inviting MECFS experts and to help exchange ideas and get other doctors more informed and educated, and opening up to the public as well. So thank you so much to everyone who's involved. There's also, of course, the Mayo Concise Review for Clinicians with the CME that was just published last October. I love to see all doctors take the CME, and I hope you encourage your fellow colleagues to take it too. And third, just even yesterday, it was announced that ME Action Scientific Director Jamie Seltzer, who co-authored the Mayo CME, she was selected for the Time 100 Health 2024, which is a huge recognition for not just Jamie, but for our entire community. So I just am so encouraged with this momentum. I also just want to really take the opportunity today to let clinicians know that there are support groups out there. There are support groups out there to help people with MECFS and also their family caregivers. They can get additional help. So patients and their family caregivers go through immense amount of stress, overwhelm, anxiety, even depression, due to these really debilitating post-infectious illnesses. Support groups can offer emotional support as well as practical advice, the day-to-day stuff that really no one else really can offer because we've lived it. We're in that boat, right? So there's Bateman Horn, there's ME Action, Mass ME, many other, but those are some of the top organizations that I'm familiar with and work with. They offer support groups to people with MECFS and long COVID and their family caregivers. So I've been leading the partner caregiver support group for ME Action for the past 5 years. And every single time we meet, I hear from people saying how much they really appreciate being able to connect with other people like them. We talk about themes like ambiguous loss, and we really help each other out. In an effort to really support people even deeper beyond these free support groups, I've launched Caregiver Wisdom. And on that website, I list the things that we offer, like blog posts, a free online community, courses, coaching, all with the intent to help people in our community. And for people who are interested in learning more about these support groups, people can go to my website at caregiverwisdom.net. And I just want to really encourage you as clinicians to tell your patients and their caregivers about these free services to really just kind of help provide a little bit more healing in a different way. And we're all in this healing kind of space. And I just like to help people who are going through all of this. So thank you so much. And Dr. Davenport, you do too. Really appreciate it.
Thank you so much, Kim. Thank you so much for being with us. And we're going to proceed with Dr. Davenport, who serves as the professor and chair of the Department of Physical Therapy in the School of Health Sciences at the University of Pacific in Stockton, California. He's a graduate of the University of Southern California's Doctor of Physical Therapy and Orthopedic Physical Therapy residency programs. He holds his Doctor of Philosophy from the University of Portsmouth, United Kingdom, in sports, health, and exercise science. Dr. Davenport is also a graduate of the Master of Public Health program at the University of California at Berkeley. He is a past clinical research fellow at the Warren G. Magnuson Clinical Center at the National Institutes of Health in Bethesda, Maryland, where his work included construction and validation of function-based physical capacity tests for patients in chronic fatigue illnesses. Dr. Davenport has extended his early work into the identification of optimal rehabilitation programs for people with chronic post-viral fatigue, such as myalgic encephalomyelitis and long COVID. He is the current chair of Long COVID Physio, an international nonprofit organization aimed at improving long COVID education and research, as well as peer support for rehabilitation professionals living with long COVID. In addition to Dr. Davenport's responsibilities as an academician, he serves as a scholarly project coordinator for the residency and fellowship programs provided by Kaiser Permanente, Northern California's Rehabilitation Services Education. Dr. Davenport is also a fierce advocate for our community, and we thank him for being here. Without further ado, Dr. Todd Davenport.
Thank you for having me. I think we need to shorten up that bio a lot, and I think we've run out of time. So does anybody have any questions? Just kidding. Kidding. I really appreciate the chance to be here. Thanks for your grace as I dissemble a little bit, finding my slides and getting them up on the screen. Let's see, I'm on two displays. I think that should be looking correct now. I mean, what a treat to be here with you all. Thank you so much for making the time and the space to do it. I really appreciate the opportunity to always follow the lived experience of people who are living with post-exertional malaise, whether from ME or from long COVID. And also to follow the wisdom of the caregiver experience for people who are providing care. You know, thank you to Renegade Research for having me. It's shocking how low the bar is to be a rebel in this field. All you have to do is follow the science and use common sense. And here we are being renegades. And thank you to ME Action. Obviously, we're so proud of Jamie, who is top 100 for time, but #1 to the rest of us, and really sort of serving as the tip of an entire operation of effective, strong advocates in this field for a long time. So I'll be talking a little bit about how to eat an elephant one bite at a time, thinking about post-exertional neuroimmune exhaustion as a bioenergetic condition. So we'll unpack a lot of those terms as we go. The QR code at the bottom, as Rochelle mentioned earlier, will take you to the form where you can register for your CME. And if I click away from that too quickly for you, you will find it cleverly hidden in the bottom right corner of every single one of my slides. So I've been in that situation where I didn't quite catch it and then needed to have some back and forth after the seminar. So I wanted to try and avoid that for you all. I also have a couple of hashtags. If you're social media oriented, please live tweet, live blog, live IG, whatever you choose as your social media device of choice. Teach me, treat me, teach ME, treat ME. Teach me, the clinician, to treat me, the patient living with post-exertional malaise. But again, teaching myalgic encephalomyelitis, treating myalgic encephalomyelitis. So there's a double meaning that I take away from that statement. And then probably if I had to summarize this entire talk in one hashtag, it would be mitochondria, not hypochondria, which I've talked about before. And it actually is not, that statement didn't originate with me, but it's one that I've sort of tried to carry forward in my own career as I think about ME and its hallmark of post-exertional neuroimmune exhaustion. So without further ado, let's get started. So I like to start because this is CME with my potential conflicts of interest, so you can decide whether I'm conflicted. I'm speaking on behalf of myself. I don't have any financial or non-financial conflicts associated with this talk. But I do serve as professor and chair of the Department of Physical Therapy at University of the Pacific here in Stockton, California, which is in the US if you're from another country. It's a beautiful day here. It's about 80 degrees. Just beautiful spring day. I'm also a research consultant at the Workwell Foundation, where I have a chance to work with Stacy and Jared Stevens. I work with Dr. Mark Van Ness, Dr. Chris Snell, complete heroes as far as I'm concerned in the research space, but also to me personally, very meaningful people to me. I've also been with Kaiser in a consulting role. I currently do help out with their scholarly projects, trying to steer them whenever I can towards ME and long COVID projects, so that our residents and fellows are learning how to provide better care. And I am proud to be the chair of long COVID physio. So you can decide if I'm conflicted. These are just the wonderful people I have a chance to work with, and they help make me smarter, which is great. Here's what I promised to talk about. So when Isabel reached out to me, I gave her 4 talking points, and I promised not to ramble too much. We will talk a little bit about the definition and importance of bioenergetics. If this is a new space for you, we'll just give some broad overview. We'll talk a lot about actually the evidence for bioenergetic impairments from the molecular perspective all the way on up to systems. We'll then discuss some current practices and future directions in testing for bioenergetic impairments, and we'll fold the current practices discussion into how we derive the evidence for bioenergetic impairments. And then finally, we'll have some discussion of bioenergetic impairments as a treatable construct or a treatable condition. So again, if you're just joining and you're interested in CME, that QR code at the bottom right corner of the screen, if you zap that with your handheld device, that will take you to the form to be able to sign up for that. I'm going to skip this. This is an extra slide. So in thinking about the overall theme, like a hook for this, because you can't just say bioenergetic impairment and expect someone to stay awake. I tried to think of a theme, and the theme is how do we research MECFS? Research in MECFS is a little bit like playing darts, where you put up a bunch of themes on a dartboard, and if you throw a dart at it, you're very likely to be correct. Just because MECFS, we know, is a multi-system, multi-symptom constellation that results in disablement. And so trying to unpack this sort of tangled web of pathophysiologies is difficult. And it's a little bit like eating an elephant in that it is best done one bite at a time. So going back to the elephant analogy here, you may have seen this. I put this up on a slide before. We look at MECFS through our respective silos. And, if I'm here on the corner and I'm poking on the edge of the elephant's tusk, I might think that was a spear. Or if I'm riding on top of the elephant and I'm experiencing the wind of it flapping its ears, I might think it's a fan. Or if I'm tugging on its tail, I might think it's a rope. And I think we approach MECFS in these various different from our various different siloed perspectives. And what we need is a perspective to try and get upstream and find the proximate causes, particularly of functional disability. And I think this is why a bioenergetics perspective always spoke to me. In my bio, that was way too long. You heard the words health, exercise, and sports science. And you heard the word physical therapist. This is my background. And so just being aware that that's the disciplinary perspective that I come from. And so probably why a bioenergetic approach speaks to me the most, but I think also has great functional utility for patients as well. Bioenergetics is how cells transform energy. Really is reflective of the flow of energy from the environment, from the biosphere through a specific organism. It has everything to do with how cells and systems produce, store, and consume, in particular, this molecule called adenosine triphosphate. The two major types in eukaryotes are cellular respiration and photosynthesis. And so these are, sort of the foundational processes by which, energy molecules are created and processed and transformed and consumed. Really, it has a lot to do with the interaction between the environment and an animal. You have processes related to energy consumption and storage occurring in the nucleus and in the cytosol, and also in the mitochondria, which are the powerhouse of the cell. And these are influenced in turn by genetic factors, the genome that is heritable, as well as epigenetic factors that are accountable for intragenerational modifications to cellular function, and some of which can be passed down to subsequent generations. So they're really kind of the cellular mechanism of environmental adaptation within the generation. Here is sort of the main event. This is the citric acid cycle, the tricarboxylic acid cycle, the Krebs cycle. Also the thing that traumatizes many biology majors and health science students. It is one of the first things we learn and one of the first things we try so hard to forget. But it turns out to be very foundational to this question of, why don't people with ME have energy? And so I won't sort of rehash a lot of the basics here, but the key steps are up here in the corner. Get my laser pointer out. You have pyruvate molecule, which is split from glucose, and the pyruvate molecule is split into acetyl-CoA through this enzyme called pyruvate dehydrogenase. So there's your Scrabble word for the day. If you hit the triple word score on that, you'll retire famous. And then it's really this conversion of acetyl-CoA to citrate that begins the process of developing the kind of skipping the electrons down an electron transport chain that allows for the molecule to become energized that becomes ATP. And it really, at the risk of getting too far into a lot of the biochemistry here, I just wanted to sort of show that there is this alternating potential where these electrons are following gradients in one step, and they're being sort of pushed across a membrane in another step. So each of the steps in the cycle that you saw was essentially an electron being pushed on one side of a membrane or being pumped actively to the other side in the presence of hydrogen, water, and a molecule called NAD that has a positive charge. And so it can be further conceptualized as sort of this construct where you have this sort of flow of the electron on one side of the membrane and being sort of pumped to the other side of the membrane and then flow to the next side. So this is alternation that occurs across the membrane, and it really follows the electrical charge of the across that membrane. This really looks like a battery. actually, kind of a little bit how a battery works. And so this is, I just wanted to kind of give a visual representation of some of this, because I think where a lot of it, at least my instruction, starts and stops is that circular diagram that you see, but just to get a sense of the shape and the potential structure of how these energy molecules are energized to be used. And so, you know, this literature is constantly changing. This paper came out 2 days ago, published online May 1st. It's a great narrative review of how latent viral activation may cause epigenetic reprogramming in MECFS, with some wonderful overview, and also some great, you know, just some great graphics, which I always appreciate. But, you know, the thought here is that, you know, there may be some kind of precipitating event that results in particular, Epstein-Barr virus reactivation in this construct, and an inefficient immune response, which we know to be true of people with MECFS, which results in, you know, an increase in Epstein-Barr virus, you know, viral proteins, RNAs that then affect the host epigenome, in particular for the mitochondrial DNA, and also affect cellular metabolism through the increase in cellular metabolites, reduction in oxidative phosphorylation capacity, which refers to the energization of those molecules, which then these metabolites and enzymes also can play onto the host epigenome, which result in these modifications of methylating DNA, modifying histones, and also increasing microRNAs. And so they also did a very nice sort of overview of the literature associated with each of these processes. And here in yellow, they highlighted where epigenetic factors are modified in mitochondrial DNA through both the process of methylation as well as RNA modifications, and primarily here associated with various immune cells, because that was the focus of the paper. Which I think it was a great read. It's one of those that I'm going to be reading a few more times just to really sort of try and soak up all the goodness that was in it. And I would, as is my privilege, I would editorialize that, you know, look, these precipitating factors can result in energy strain. They can increase allostatic load. They can increase the stress response, which then may act directly on cells. Those cells then have a hard time sort of engaging in those processes that we discussed about how to energize those molecules, process those molecules, which then, you know, will result in sending erroneous signals to the periphery about how much blood do I need? Do I need to mobilize glucose? You know, so if there's problems at the mitochondrial, at the cellular level, there's going to be abnormal cell signaling too. Kind of the neurohumoral response to position changes in exercise, which can result in impaired blood flow, either through baroreflex in response to position changes, or the metabolic reflex in response to the local accumulation of waste products within skeletal muscle that irritate afferents, type 3 and type 4 afferents, in order to stimulate an increase in heart rate, to start clearing some of those products and, you know, improving blood flow to the skeletal muscle, start to shunt the blood flow away from systemic circulation. And with impaired blood flow, obviously comes too much, not too little oxygen, too much carbon dioxide, and poor glycemic control, which can then create the situation of epigenetic modifications. And so this is kind of when those good little beans, mitochondria, start to go bad. And this is maybe another way that this can happen in, maybe not even instead of, but in addition to viral reactivation, which we know is common in people with ME. So I used another 25-cent word in my title, which was post-exertional neuroimmune exhaustion. And I want to unpack it just briefly here. And the idea is, a lot of people know what post-exertional malaise is. They have a sense of what post-exertional malaise is. But this is a purpose, an intentional difference that I'm using here, because I think post-exertional neuroimmune exhaustion probably best captures post-exertional malaise, but you won't see me using post-exertional neuroimmune exhaustion very much in my public communications because folks are less familiar with it. But since we're all friends here, many clinicians, people with lived experience, post-exertional neuroimmune exhaustion comes from the international consensus criteria for ME, defining myalgic encephalomyelitis, and defining it with this compulsory criterion of marked rapid physical or cognitive fatigability in response to exertion, post-exertional symptom exacerbation, post-exertional exhaustion, a prolonged recovery period, and a low threshold of physical and mental fatigability, resulting in a substantial reduction in pre-illness activity level, in addition to the potential that threshold can become lower, and often becomes lower, which I think differentiates post-exertional neuroimmune exhaustion from a lot of other forms of fatigue and other disease states. So, so these are compulsory, and so and they're very specific. And what you'll notice is that post-exertional malaise is not here. The rationale of the authors, and one that I hear from people with lived experience, is malaise is very general. It's hard to define. Some people think it's pejorative, and that's kind of the last thing we need is yet another pejorative term in this field. But post-exertional malaise is sort of sticky. It's with us. People sort of know about it. So again, I sort of use it. I use it more, but with mixed emotions about that. I also want to point out that a synonym for post-exertional malaise is sometimes post-exertional symptom exacerbation. And that's just basically saying that signs and symptoms get worse after exertion. And it's not very specific to post-exertional neuroimmune exhaustion, but it is one of the criteria for it. So I point that out because PESE is favored among people with long COVID, and I strongly believe that the people who live with an illness should have a heavy hand in naming it. But I will point out some of the problems with differentiating PESE from PENE, as PESE is just one component. So just to kind of cover some of the rest of this slide for completeness sake, even though it's not exactly what we're talking about today. Here we have at least one symptom from 3 of the 4 categories of neurological impairments required for the diagnosis of myalgic encephalomyelitis. 1 symptom from 3 of the 5 categories from immune, gastrointestinal, and genitourinary impairments. And then finally, this is more germane to our discussion here, energy production and transportation impairment, involving at least one of these criteria. So I like to just bring this up because I think this is the most specific set of case definition criteria, and one that I try to follow. And it is sort of my implicit understanding that when I talk about post-exertional malaise, I am talking about post-exertional neuroimmune exhaustion, even though I'm not being precise with my language, and I've got my reasons for that. At the Workwell Foundation, we've developed a clinical staging for post-exertional symptoms because we realize that not all symptoms are necessarily created equally. The symptom experience of post-exertional neuroimmune exhaustion or post-exertional malaise is highly individualized. As a clinician, you have to get to know your patient in order to understand how they are experiencing post-exertional signs and symptoms, and specifically what they are impacting, to get a sense of sort of scope and severity. But in general, what we can say is that immediate post-exertional symptoms are often this sense of kind of muscle burning, maybe out of breath, dizzy, nauseous. We think of these, who do exercise testing think of these as being very common after an exercise test, but they go away very quickly. But in people with post-exertional neuroimmune exhaustion, they don't go away quickly. And we're not talking about needing to do a maximal exercise test. It may just have been getting up to go to the bathroom is what caused these immediate symptoms. We think about short-term symptoms as kind of reflecting overdoing activities. There may be a delay in these short-term symptoms of 48 to 72 hours. They may last 2 days to a week. And these result from either an acute overexertion, which again can be as simple as going to the bathroom once in the day, or it could be multiple times during the day, being slightly over what's possible for that person energy-wise for the day. And we think about these as muscle and joint pain, brain fog, cognitive dysfunction, headaches, and sleep disturbances. Just anecdotally, sleep disturbances seem to be a leading indicator of crashes. I can't think of anyone with ME who sleeps well. it's just not a thing. But subtle differences in sleep quality, especially in people who are mild, have mild forms of the disease, can portend crash or recovery from a crash. We think about long-term symptoms as lasting more than a week, reflecting sustained immune responses. These are flu-like symptoms, cardiopulmonary symptoms, palpitations, maybe an increase in orthostatic intolerance, as wild as that sounds, can be part of this. So people's POTS may come and go, and really sort of look like post-exertional neuroimmune exhaustion. And if it's not completely gone, it may fluctuate. So something to kind of watch for. We use cardiopulmonary exercise testing because it is commonly used in the medical system. It's valid and reliable measurement. It allows for us to assess and compare between tests, between people. There are widely adopted test criteria. We use the American College of Sports Medicine criteria for our cardiopulmonary exercise testing methodology, as well as our interpretation. So it's rather standardized, and so it can be a useful tool in the right person. Not for everybody, but for the right person, it can be very, very useful. Just as an aside, if you joined late and you want CME credit, please zap that QR code in the corner if you haven't already. If you're not curious enough to have done it already, do it now. It'll take you to your CME form. I turn my laser pointer off because that'll get annoying. So here we have what happens in the body in terms of what energy systems we think are being used during a cardiopulmonary exercise test. So you sit down on the cycloergometer, you have a mask, a well-fitting mask with a tube leading to a sensor, leading to a computer. That sensor is going to measure the amount of oxygen and carbon dioxide in your breath. And after we've explained everything, make sure that the bike fits you. We'll have you begin cycling on the cycloergometer, and progressively we will make it a little bit harder. But the request is for you to continue cycling at a constant rate. So you're not going faster. Nobody's running. It really is, we're increasing the load with a constant cadence. And so the first energy system you'll use is whatever's laying around in your skeletal muscle. So you'll use the free creatine and muscle glycogen. There's creatine kinase, which is the key enzyme there, which generally for every molecule of creatine that you break down, you get 1 ATP. So it's not super efficient, but it's enough to get you started. And then after about 2 minutes, maybe starting around 90 seconds and going kind of through most of the CPET task or through most of your progressive task, you have this long-term energy system, which we think about as being aerobic glycolysis. So you're using oxidative phosphorylation, that cycle we talked about earlier, which again is mediated by the many metabolites, nets 36 ATP at a time. And then towards the end, you start generating lactate, and your body will try to convert that lactate into glucose, and you actually lose energy molecules in the process. So it's a highly inefficient process, but it keeps you from just stopping in your tracks to be eaten by the saber-toothed tiger that you're running away from. And so obviously people are not going to be able to operate in this deficit for very long. And we see this on an exercise test, that once you've passed the point where you're into that high intensity energy system, then you don't have very much longer you're going to pedal. And so why is that? Well, so as byproducts of aerobic metabolism, there is an increase in hydrogen ions. So the body becomes more acidic through lactate. And there's also the generation of reactive oxygen species, which will interfere with this citric acid cycle or tricarboxylic acid cycle. And so the great irony here is that the most powerful energy system we have operates in such a way that ends up creating products that defeat itself. And so we can't, this is an energy system that is finite. It doesn't go forever. Here's what the CPET data looks like when we get it off the metabolic cart or off the computer. And what we're doing here is this kind of the key thing to look at here would be this kind of volume of carbon dioxide and volume of oxygen. We're doing a breath average, so we take every 7 breaths and we just take the middle 5 of those just to smooth things out, so that if you have a breath that was excessively deep or shallow, then it's not likely to get counted. And what you end up is you plot the VCO2 by VO2, and you have a nice upward slope. This suggests that the body is, sort of creating energy molecules by increasing the amount of oxygen consumed, but in scale with the amount of carbon dioxide breathed off. But then you'll notice that there's sort of an inflection point here where things change. And then what happens is for every oxygen molecule you take on, you increase the amount of CO2 carbon dioxide that you're breathing out. So this is because that carbon dioxide is retained in order to try and buffer those hydrogen ions. So after this break point, we would surmise now that the person from whose measurements we generated this chart is now beginning to metabolize less and less and less using oxygen, and more using anaerobic means instead. So there's other plots here. I won't spend a lot of time talking about those other plots, but I will point out that for every exercise test, there are like 5 checks in order to figure out where this break point is, where the rate of carbon dioxide being breathed off starts to occur out of scale with the amount of oxygen taken on. And we call this has a name, it's called anaerobic threshold. We call it ventilatory anaerobic threshold, or VAT, because we are looking at this from ventilatory data. So in other words, the breath data. Sometimes this anaerobic threshold is called a lactate threshold because around the same time, there's an increase in lactate concentration being observed as a byproduct of anaerobic metabolism. So the lactate threshold and the ventilatory anaerobic threshold are correlated. And so we tend to use breath data because it's less painful, uncomfortable, messy to collect blood during a test periodically, but that is another way that you can derive that data. So there are criteria, published criteria to achieve a maximal test. And, the American College of Sports Medicine says that, there needs to be a plateau in oxygen consumption with increases in workloads. In other words, you need to be done taking on more oxygen at the max. That just suggests that the system is no longer taking on any more oxygen, not using it. Rating of perceived exertion over 18 or over, which is a rating of working very, very hard. That's 18 out of 20 on a scale of 6 to 20. The respiratory exchange ratio is an important one, needs to be greater than or equal to 1.1. We often will look at 1.15 as being important. And then also the peak blood lactate of at least 8 millimolar. And as I mentioned, we at the Workwell Foundation don't measure lactates, but it is a thing to do. It's important to remember the patient doesn't know anything about this beforehand. Like, we're not telling people, hey, when you hit 18, you're done. There is a lot of encouragement to make sure that we get a clean maximal test. And we think about the RER as generally being the most valid because that RER is the volume of carbon dioxide to oxygen. And, we're measuring it from the gas composition of the air that you breathe out. It's extremely difficult to fake, especially under submaximal levels of exertion, because remember, we're going back afterwards and picking where that ventilatory anaerobic threshold was after the test, not during the test. In fact, it's almost impossible to figure that out during the test, just because of how a lot of the data is organized. It's organized by breath, not by time. So if you can I've been in this field for 15 years and I'm still trying to wrap my head around it. But it's this is one of the reasons why you have to go back after the test instead of during. So if you hear people saying, well, we'll just stop the test at the heart rate of ventilatory anaerobic threshold, that becomes a chicken and egg question that I'm just not technically very comfortable with. A high respiratory exchange ratio is not possible in this population without high voluntary effort, because remember, what it suggests is that the pH of the blood has reduced to the point that it must be buffered in order to bring it back up. So again, I don't know how you fake your blood pH, but that's I guess that's another roundtable. And I think critically, this removes the issue of voluntary effort or effort preference. You either got the RER value or you didn't. There's no debate about sort of what physiologically is going on. And there's lots of reasons why a person might not achieve an RER of 1.1 or above, but and volitionally ending a test early is one of those. But, if a person has an RER of 1.1 or above, we can say some very specific things about what their physiology has been, which is nice because it kind of removes the conditions for some recent contentious debate. Why CPET? Well, we can look at CPET across various different health conditions, including people who are really ill. And we can detect small changes in cardiac, pulmonary, and metabolic status between people, between different clinical populations. And there's a whole literature of test-retest reliability studies involving CPET in these populations. As well, there should. I mean, you want to make sure that this test is at least reliable before you start rolling it out clinically and start using it, right? So you would hope that there would be test-retest data, or somebody would at least at one point have thought to work out whether these measurements are reliable. And what I can say based on these data is that even though people are ill, even though they have, may have significant disabilities, all of these conditions can reproduce an exercise test within about 8%. So pretty stable, pretty steady. And in fact, what we see in deconditioned people is we see folks actually get better on the second test, if you can believe that. So folks who are out of shape, they kind of have the experience of the first test to inform the second test, so they gain a little bit of what we might call biomechanical efficiency. Maybe they have an acute jump in plasma volume that helps them with a little cardiovascular efficiency. But regardless of the mechanism, they seem to do a little better. So reproduce or even maybe slightly improve on the second test. I mean, I really appreciate Kim calling out Stacy Stevens, because she's really been a pioneer in this field and she's been doing this work for a long time. And a lot of what we know surrounds the Stevens protocol, or the 2-day CPET, which was developed by Stacy when she was a grad student here at University of the Pacific, and continued to work to refine it ever since. Here's what it involves. I mean, there's some pre-testing that's done, questionnaire data, obviously assessments for safety, physician clearance, EEG, and so forth. And then the first cardiopulmonary exercise test. And it's a maximal test on a cycloergometer. We use a recumbent cycloergometer. This is an upright one. But regardless, after that first test, we anticipate there will be post-exertional signs and symptoms. And, if you stop at this first test, what you get is sort of what you get. But one of the things you don't get in what you get is an assessment of the patient in the post-exertional state. You never come back and measure the physiology after they're symptomatic. And so the second test is really positioned to be able to make that assessment, to be able to measure the physiology of the post-exertional state. And what we found, just in broad summary, and this has sort of been replicated in labs all over the world, is that there's a reduction in the efficiency of oxidative metabolism. So there's a reduction in the amount of oxygen consumed at anaerobic threshold, and there's a reduction in work output. So we're sort of we're seeing how hard you can press against the pedals, and what we see is that at anaerobic threshold that there's a reduction in work output. And that's only on the second day of a 2-day CPET. First day, folks with ME might look like a deconditioned control participant. So that where the differences happen is on that second test. So this is a cautionary tale for all of the studies coming out using one CPET. And I know there's lots of rationale about why one CPET and wanting to balance risks and harms, which obviously is our responsibility as researchers and as clinicians. But I have to say, I mean, are we really doing the good that we could do by doing one CPET and missing the important part of the story on a consistent basis? So just food for thought. CPET also can be used to stratify severity. There's a reduction in peak and anaerobic threshold VO2s and workloads that is cascading by severity. Interestingly, all of the tests that you see here have a reduction between tests within each participant category. So interesting that CPET is sensitive to differences in sort of disability status as well. Just to give you some sense, I went and looked up the norms for the age-related norms for someone if they were deconditioned. We would say that the mild group, this ME mild group, would be in the 3.5 percentile, which means 94 people would be standing ahead of this person in line as having a better VO2 for age. And for this moderate group, we're in the 0.7 percentile, which means 99 people are now standing in line ahead of that person as having a better VO2 for age. And of course, by the time you get to severe, you're at the 0.3 percentile. So it's just still 99 people, but even worse. So just to give an idea of the functional effect, the functional impact of this disease on bioenergetic processes. there's differences in test 1 and test 2. This is just another way to express this. At ventilatory anaerobic threshold, these are standardized effect sizes over here, and you can see that they're moderate and that they increase to large differences on the second test at VAT. And so again, people are just having huge differences in anaerobic threshold, VO2 and workload, and heart rate, and blood pressure compared to deconditioned controls. Who cares? Like, that's all very nice to know, and, some nice figures and so forth. Well, as a physical therapist, I get really interested in function. And so the other way to think about anaerobic threshold is this is your ceiling for functional activities. People do not function above their anaerobic threshold very well for very long. So people tend to stay away from that as much as they can, including me. Now, my VAT is going up a flight of stairs. So I tend to take my time and pace that. So I don't lose my breath at the top and get all sweaty and have to catch my breath. But that's my body's way of rebuffering and sort of reloading. People with post-exertional neuroimmune exhaustion don't have that same capacity. The loading takes longer. The interest rate on the credit card is higher. And so you can see that in this chart. The items in bold are different between people with MECFS and sedentary individuals in terms of the ability to do these activities, given some of the average metabolic output on exercise tests that we have conducted. And so you can see that food preparation is too hard for these ambulatory folks who, may be on the mild to moderate end of the spectrum, who come into our clinic. Making the bed, playing with children, scrubbing the floors, sweeping and vacuuming, walking not super fast, washing the windows. These are all over the energy limits that we have measured in our lab. And so these are things to kind of consider as a clinician, because when I first started working with people who have ME, I had a really hard time believing that, wow, really, that you make the bed and then you have to be in it for how long in order to recover? I couldn't get my head around it. But here we have physiological data that just confirms the lived experience. So, if there's a moral of the story here, it would be just to listen to people. As we talked about that, here we have a study of lactate accumulation during a cardiopulmonary exercise test, focusing on the middle chart. The gray is controls, lower line. The darker line and higher line is MECFS. So you can see that at rest, people were pretty similar, but the groups diverged such that folks with MECFS, based on the power output during the test, had a greater increase in the development of lactate during exercise. So here's another example of how people with ME are spending less time metabolizing aerobically and more time potentially in an anaerobic state. And here you see the individual wise chart here, where you have the controls in blue and you have the folks with MECFS in red. And this lactate accumulation curve tends to get shifted to the left for people with MECFS, suggesting that per power output per body weight, they have a greater increase in accumulation of lactate compared to control. So here again is another just sort of example of how folks with MECFS have impairment, really, of their ability to metabolize using oxygen and also clear lactate. I'm referencing a systematic review here of various different studies that kind of go over the molecular suggestion from molecular data that these individuals are metabolizing more anaerobically. So there's an elevated lactate accumulation in cerebral spinal fluid. There's an elevated creatinine, reduced pyruvate and alanine, elevated glucose, leading to some glycemic instability in some individuals, and then also various reduced components of the TCA cycle, suggesting reduced glycolysis. And this is from various different studies in a systematic review that was published in 21. Another study that is just a classic is the finding that that specific enzyme that catalyzes the conversion of pyruvate to acetyl-CoA, which is called pyruvate dehydrogenase, is impaired in people with MECFS. So, these are folks that just don't have the substrate to be able to enter into the TCA cycle. And, maybe a potential therapeutic target. Most recently, the Appelman study got a lot of attention in long COVID. They used the word post-exertional malaise in a title in Nature, and I was just so excited about that. Just a really great study. They looked into, markers of cellular respiration, ultimately found that, people with long COVID had an exertion-dependent reduction in oxidative phosphorylation capacity, as well as an enzyme called succinate dehydrogenase, which is one of the parts of the circle that is also found to be reduced in people with long COVID. In addition, found in skeletal muscle anything downstream of pyruvate in the post-exertional state, in particular, being reduced in people with long COVID compared to controls. So again, just really some compelling information here that the ability to produce and consume energy is abnormal. Another big omics study that looked into subgrouping or subtyping folks based on metabolic signature. You have the first subgroup, which was increased more towards a ketogenic metabolic state involving the metabolizing fatty acids and proteins, shifting away from using carbohydrate. In addition, another subgroup that had sort of a decrease in this mitochondrial oxidation of pyruvate. So again, we saw that in the preceding studies that pyruvate production or acetyl-CoA production is potentially an issue. And then this third subgroup, which was very similar to healthy controls, and not very many, but again, represents maybe a spectrum of disease here that we need to consider. But that those first two subgroups really are suggestive that there is energy strain, that the bioenergetic process of metabolizing carbohydrate is abnormal. I try not to let people get away without my clinical analogy that I use with patients, and sometimes I use with clinicians who are new in this area, is that interestingly enough, your body is a lot like a plug-in hybrid car and how it consumes energy. Obviously, plug-in hybrid cars have a battery. Battery is great for things like flat surfaces, stop-and-go traffic, going in the city, short distances. It also has a gas motor. The gas motor is great for things like going freeway speeds, hauling people in gear, going up and down hills, and it also charges the battery. And so the analogy with ME, post-exertional neuroimmune exhaustion, is that now you have a gas motor that is working abnormally, and so it no longer charges the battery, and you no longer have the ability to do higher intensity activities. So I really that sometimes is a crystallizing analogy for people to really kind of understand what's going on, and I think it captures pretty well some of the science there in a more digestible format. So what can we do that's not a cardiopulmonary exercise test? I get this question a lot. I think it's a totally reasonable question, and it's something that we're pursuing. One way is to try and measure that muscle metabolic reflex activation, which occurs in response to the accumulation of lactate in skeletal muscle. And it causes, essentially, it triggers the cardiovascular response associated with increasing your heart rate. And so this technology essentially allows us to, potentially elicit signatures of post-exertional malaise at lower loads. And there may be some similar technologies here. We're using hand grip dynamometer with a blood pressure cuff, measuring heart rate for heart rate variability is the specific signature we're looking at. But, there are some other methodologies out there. They may operate kind of similarly with the kind of an exercise pressor type of a reflex, like Alain Moreau's therapeutic massage device might actually be creating some of this, some similar type of an effect. But, the hope here is that we'll be able to standardize the exertion, because unfortunately, I don't think we're ever going to get away from a circumstance that someone with quote unquote fatigue is going to be believed if we don't have some kind of marker of effort. And I think we can have kind of a marker of effort through that hand grip dynamometer that you see that person in the diagram holding. So for now, until we get people actually believing patients, we'll be measuring those outputs. So I have just a few more minutes here. Thank you for hanging in there. I just want to talk a little bit about how to address bioenergetic impairments. Lots more future directions in this slide than there are current best practices, obviously. And I want to just have a little caveat that, I'm a physical therapist here, and I don't prescribe medications. And so your mileage may vary depending on your background. There may be some additional medications and so forth and tools in your clinical repertoire that you have access to that I don't. So I will be handling things more from kind of a rehab perspective on this, and from more of a dietary supplement type of a perspective. But in general, we want to try and reduce energy strain and support metabolic functioning. And we want to do this because essentially what we think is the more time you spend in anaerobic metabolism or over that anaerobic threshold, the longer we think you're going to be, or the more increase in risk you may have for aggravating your functional impairment associated with post-exertional neuroimmune exhaustion. And conversely, we think that we can keep you in a zone where you're using immediate and short-term energy systems that work, we may be decreasing that risk. So this is where I talk about pacing. And I think about pacing as a core competency in someone with living with post-exertional neuroimmune exhaustion. There are so many limits to pacing that we probably could do an entire roundtable on just the limits. but be that as it may, this is probably the most, I would say it's probably the most effective tool we have right now, which is not saying a whole lot because that bar is extremely low. But if you're a clinician wondering how to get started with a pacing program, the first thing is to identify the specific trigger of that a patient may have for a specific set of symptoms and signs. And this may be physical. So we talked a ton about physical. We have not touched cognitive, emotional, environmental, sensory, but they're all there. Just because I am a physical therapist and an exercise scientist does not, and I talk about physical activity does not mean that the rest of them are not critical. And really what it comes down to is investing the time to get to know your patient, their routine, their desired activities, what their key signs and symptoms are, and developing a shared sense of what the plan's going to be. Pacing programs are never specifically prescriptive. So you start with analyzing the task, scaling the task, and then moving towards attainable movements and functions for your patient. And I want to credit Amy Mooney, who's an outstanding occupational therapist in the Chicago area, who I love working with, and she makes me smarter through advice like this to get started. Here are the kind of the evidence-based supplements for metabolic support. Again, your mileage will vary with this. There are myriad different sensitivities. There are so many problems with dietary supplements because it's an unregulated industry. We're taking people's word for it that what's on the bottle is what's in the pill. But you can see the oxaloacetate, CoQ10, beta-glucan, NADH. Those all are sort of directly supporting potential deficiencies in the TCA cycle, as long as your body knows to put them there after they're digested. The probiotics may be useful for the subset of people, a lot of people with irritable bowel syndrome, and then the high cocoa polyphenol rich chocolate. I've never seen that used. It's an amazing idea, but that's just because I like chocolate. But I know that there are plenty of sensitivities and folks in whom that would be not a good idea. So, if you're a patient listening in, if this is anything new to you and you're taking notes, please work with your healthcare provider on this. If you are a healthcare provider, obviously use your clinical judgment. I like to circulate this clinical playbook. Notice that I use PEM and PESE at the top because, again, that's what everybody says. And it gives some guidance for assessment and for pacing and for different supportive interventions to improve blood flow, maintain blood flow, and as well as a few simple criteria to get started for pacing. So do feel free to use that. We can certainly circulate this after the talk as well. So I'd say our key takeaways would be that PENE is in part a bioenergetic deficiency. It's a lot of things. Remember that cells have mitochondria. So, I would say that, a lot of the hypotheses surrounding immune dysfunction, neurological dysfunction, and so forth are not incompatible with the fact that there may be an underlying bioenergetic deficiency either associated with or the cause of this issue. But the important thing to remember is that the bioenergetic piece is a pretty easy conceptual link with function, and so it's a pretty easy link for patients to make, and I think it's an important one that we continue to investigate because of the importance of energy production and consumption for completion of normal activities of daily living. And that bioenergetic deficiencies can be a treatable proximate cause of symptoms and disablement. Our tools are not great. We need better tools. And we would say a future direction in this area is to continue to consider a bioenergetic perspective of post-exertional neuroimmune exhaustion alongside the others that are getting some very well-deserved attention right now. All right. You made it. Thank you. Questions or comments?
We have some questions in the chat, and we'll go to Rochelle.
All right, I'm going to be unmuting participants that are have questions that they have come up. So if you are, hopefully you guys can see that you've been unmuted if that's the case. So the first one to start off with is Anne Rumwitowski. I think I unmuted you. I'm sorry, I think I did.
Oh, yep. Thank you so much for this presentation. I was wondering if you could talk a little bit about balancing the sort of the CPET test with what you mentioned earlier on in the presentation, which is that overexertion can sometimes permanently lower a patient's baseline. So yeah, how do you decide sort of when to do the CPET and what are the concerns related to that?
What a great question. And thanks for bringing it up because I think it's really important. So some of the important, concerns are making sure that the patient obviously is aware of the potential for lowering baseline. We expect this. We expect at least a temporary lowering because the thought is that we're trying to position that measurement in the post-exertional state, meaning there will be one with corresponding symptoms and signs. Thankfully, we don't see permanent baseline lowerings often, very infrequently. And I think the Jeff Moore paper that recently came out, co-authored by Maureen Hansen and Stacy Stevens in the author line there, kind of gave a roadmap for how long it takes generally for people who have ME and who participate in a CPET to recover. And if I remember correctly, 90% of patients were recovered to baseline within 3 weeks. But, you know, again, as you point out, we're using exercise as a stressor. We're trying to use it in a controlled manner with you know, real-time physiological monitoring. This person who's done hundreds of CPETs and so is very experienced. And so those are the ways that we try and balance risk. We also try and work with as much as possible, you know, physicians who know their patients well and can help sort of assess risk and benefit of the CPET test. And, you know, for the future, trying to mitigate the need for a CPET potentially by trying to get the same type of information in a different way, even in something that potentially could be done at home by squeezing a hand grip dynamometer instead of doing a CPET test.
There's Todd, somebody has asked if you'd be able to put the slide up again with the various activities and their energy values again.
Yeah, let me see if I can do that. I will try and do that in such a way that doesn't make everybody motion sick. So if you have sensitivity, please look away because I'm going to go back a few. There we go.
And then the next question is coming from Nita Jane.
Hi, Dr. Davenport. I had a question on the therapeutics front, and I just wondered if you had any insights into whether any sort of peptide therapies might be effective to address the metabolic disturbances that you see in MECFS. I obviously know that, obviously BPC 157 has gained a lot of notoriety in our community, perhaps, but there are quite a few others, some of them even of mitochondrial origin, like MOTS-c, and if you had any thoughts on that being a potential therapeutic route.
Yeah, thank you. And I it's a good question. And I think there are a number of really promising molecules out there that could be helpful. I think what we need are trials. And so you'll notice that all that I put up there were basically the things that had some kind of at least phase 2 evidence. The bar is very low. And I would love to see some of these molecules tested, and particularly using some kind of a post-exertional challenge to be able to assess the potential effects on mitochondrial function. There are some non-invasive ways that we can do that, and I am all on board with that. Yeah, very promising candidates, and would just love to see trials.
Definitely makes sense. Thank you.
Thank you.
And the next question is from an attendee that does using the heart rate monitoring pacing thresholds technique change if the patient is taking heart medication, reducing medication for POTS?
That is an excellent question. And the answer is no, because the dosages of the beta antagonist medications that are used are not sufficient enough to interfere with those heart rates at anaerobic threshold. For people who need significant rate control or significant control, then there can be some interference. But at the dosages we commonly see for orthostatic intolerance, our experience has been that you can still use a heart rate monitor. If you are in the situation that you're using a heart rate monitor and the data is not making a whole lot of sense, and the medication may have something to do with it, there is this principle that we always follow, that patients should not ignore how they feel. And so there may be some supplementation of that heart rate data with, again, not ignoring how you feel, and getting a sense of how to adapt some of the heart rate guidance, the guidance for heart rate based pacing in accordance with your own individual needs.
All right, and our next question comes from Victoria Copeland. Victoria, if you're ready. Okay, no, I'll just move on to the next one, and then we'll go back to, I can just ask Victoria's question and see if you're ready to answer that one. What are some of the main barriers to getting some of this newer testing done through different tools, such as that hand grip test?
Great question. So the main barrier is that we don't have a product yet. So I have friends in the engineering department here at school who put up with my various flights of fancy. And one of them, I've sort of asked my my engineering colleagues to put a couple of enterprising students on this project. So hopefully we will have a setup that would be conducive for someone to do this simply. So that'd be the first piece, is to make sure that the technology is feasible and that it works well, and we think we have a good setup. And then the second barrier is that we haven't validated this methodology in people living with ME or with long COVID. And so that would be the next step, is to determine whether there are those important differences that we think might exist that are indicative of post-exertional neuroimmune exhaustion actually exist. So this is a technology that's basically been used in various different applied phys labs for people with heart failure, college students, as demonstrations and so forth. So we're trying to use this technology now in this new way. And so there are the attendant problems with working out the bugs before it's rolled out for wider consumption. So thank you for your patience with us as we figure that out.
Okay, and then I know we've got a couple of our panelists that had a couple of questions, so they're also coming in, everybody's coming in at the same time, trying to prioritize everybody else at the same time. But the next one that came in really first would be Cynthia Johnson. Let me give her a chance to talk. All right, Cynthia, you're up.
Can you hear me?
Yeah,
Yes.
thank you, Cynthia.
Oh, great. Thank you. This was a great talk. I've suffered from ME since 2009 and was sent to physical therapy early on, and it did a lot of damage. So this is a really wonderful presentation to see. Thank you so much. But I wanted to know how are you getting the word out to physical therapists? I mean, this is a really timely and important topic that you're dealing with, particularly now that I have concerns that people at post-COVID may well be sent to physical therapy without a good understanding.
Yeah, thank you for that comment, Cynthia. And I'm sorry to hear that that physical therapy was sort of a negative part of your story.
Yeah, thank you for doing this, because it obviously doesn't have to be. So thank you.
Yeah, and thanks for that. Also, I perceive in that a second chance, which I also appreciate. Great question, well taken. People hear physical therapist and they hear exercise scientist, and that's already two strikes against me. So I get it. I think that we have a long way to go in educating our colleagues in the US and across the world. Part of why I'm involved in long COVID physio is because I'm really interested in that educational component. So I've been involved in various educational initiatives, started a partnership with I Can CME in Canada, helping with developing continuing medical education. Excited to work with David Petrino and Mount Sinai on some of their CME work as well. I've given talks at American Physical Therapy Association combined sections. They had a cross-section working academy, working group for long COVID, which we brought a lot of ME concepts forward into, obviously. And so trying to be really active, I guess, Cynthia, in short, not saying no to anything and just trying to get the word out.
All right, and our
It's
next one
much
is from,
appreciated. Thank you.
Thank you.
our next question is from Alyssa. If you are ready, Alyssa Halpin.
Thank you. It's already been answered. Essentially, someone asked a really similar question. So it's great. Just
Okay.
thank you for this talk. I'm really enjoying it.
Thanks,
All
Alyssa.
right. Thank you. And then our next one would be from, will be from Nick Melia. Just a second, let me get Melia. Let me get. All right, there we go. All right, Nick, go ahead.
Hi, Todd. Thanks for the talk. It's really informative. Yeah, would you consider that a post-exertional neuroimmune exhaustion? Do you think there's a direct, like, metabolic failure in the sensory neurons or the vagal afferents themselves? Or do you think there's a larger sort of neuroimmune failure, like that's central, that's leading to the loss of metabolic failure or the loss of physiological reflexes?
Yeah, thanks for the question, Nick, and it's good to hear your voice again. I hope you're doing okay. Yeah, both, potentially both. You know, when I look at a cell, I think about the mitochondria, and as you know, circulating virus, with the integration of multiple systems, the potential for regional hypoxia from abnormal mitochondrial signaling can affect any number of them. Probably differently in the central nervous system, obviously, than the peripheral nervous system and systems in the periphery. But yeah, that's one that it's hard to parse, and I totally acknowledge it's hard to parse. So I'm leaving space in my thinking for both. But obviously, as a mitochondriac, I would kind of lean towards the fact that there may be widespread dysfunction in cells.
Thank you.
All right, and then our next one's going to come from Suzanne Ducker. Suzanne, whenever you're ready.
Hi, yes, thank you. Outstanding presentation. It appears to me that my primary symptom after 3.5 years of this is the orthostatic intolerance. And yet it seems to have a PEM acutely associated with that. And I guess I just get confused between reading about mitochondria, which are associated with muscles. I don't seem to have muscle fatigue per se, but I see my muscles vanishing after 3 years. But or is this a nervous problem? And I guess I asked that question because I don't know whether to lay in bed and try to stop it altogether or whether to try to keep pushing. It's just absolutely confusing to me where the problem is lying.
Yeah, thank you. Yeah, thank you for that question, Suzanne. And I'm sorry this is happening to you. It's sort of a lot of really challenging things at once. I think, and there's a couple of slides I actually took out of this talk about the signaling that takes place on the inside of blood vessels, the vascular endothelium, and the importance of these reactive oxygen species, or the byproducts of inflammation, the byproducts of cellular metabolism in regulating the vascular endothelium. So, the way I sort of have this all worked out in my mind, and this is hypothesis building here, is, if you have abnormal mitochondrial signaling, then there's going to be sort of a wide, and this maybe gets back to some of Nick's question, there may be a wider that might influence some wider, abnormal reflex for distributing blood flow that results in, metabolite reflex dysfunction and results in orthostatic dysfunction. So I see those. I see the mitochondria as kind of potentially playing a role even in orthostatic intolerance. And to just address really quickly, Suzanne, your last comment of I don't know if I should push or if I should lay down. If you have signs and symptoms of post-exertional neuroimmune exhaustion, the answer is to PACE. Pacing is the core competency in all of this. And I know there's a lot of conflict right now between kind of advice and dysautonomia that would suggest, hey, if you just exercise enough, you'll get past it. And that just hasn't been the patient experience. And in fact, we have a case study coming out hopefully soon that describes the how we helped a patient with POTS, younger gal with POTS, to improve clinically, go back to school, marching band, and so forth, with pacing instead of with the kind of the predominant exercise-based approach that we see a lot of dysautonomia clinics using.
Thank you.
You're welcome.
All right. One last question, because I believe you have to take off here pretty soon. So, so we've got one question. Veronica Morales, if you are ready.
Thank you. Hi, Todd. How are you? Thank you very much for this great talk as always, and for enlightening us with everything yet you know. I think we talk a little bit about this, but I kept wondering because, you know, it's obvious that pacing works, and we were talking about how pacing would actually give room for those damaged mitochondria to kind of, you know, that we could get rid of those cells that have damaged mitochondria. So would this really explain why people that are diagnosed early would have a higher chance of recovery as compared to those that, you know, have been suffering from the PEM for longer, and therefore maybe they've been having some epigenetic changes to their DNA, so we can't actually feel that those mitochondria, we are not, I mean, it wouldn't be that easy to get rid of that change at that time. That would be kind of part one of the question. And the second one would be, you know, thinking a little bit about these positive effects of metformin. Would this be the reason, and would this explain why the least we have glucose around, would that help the same way with a pyruvate hydrogenase to actually, you know, kind of allow it to work better even when it doesn't have full capacity?
Yeah, those are good questions. First, let me say hi, colleague. It's nice to hear your voice again, and we need to catch up again soon for sure.
We know. Thank you.
Yeah, to answer your first question, you know, mitochondria do turn over, and so you know, what we may be doing with pacing, as you point out, is you know, putting those mitochondria in a better environment to succeed, reducing sort of the ambient extracellular, intracellular and extracellular environment of waste products that sort of maybe the next generation of little beans are raised in a better way than the previous generation of little beans, and so you have a progressive increase in function. That's one hypothesis. It'd be really interesting to use some of the non-invasive measurements of cellular respiration that we have now in order to sort of see you know, what the effect of pacing might be. So that's a study we feasibly could pull together now. So that's definitely an idea. And you know, to your second point of maybe metformin helping to sequester some of the extra glucose around, you know, because really the mitochondria are no longer using glucose as a substrate. And so again, this gets back to the mitochondria potentially triggering multisystemic dysfunction, because what are they supposed to do? On the one hand, you're signaling for an increase in glucose uptake, and you're signaling hypoxia, but on the other hand, you're not using it. So then you're getting conflicting signals, which is then causing multisystemic dysfunction. So maybe metformin is helpful for some people just to improve some of that glycemic control, to reduce the mixed messages that, you know, in particular the parasympathetic nervous system is trying to process related to storing some of this extra glucose that's being circulated, even despite the fact that maybe the mitochondria are saying, maybe the cells are saying they need it, even though the mitochondria aren't using it. So the glucose is getting caught in the middle.
Great. Thanks very much.
Thank you.
I was talking on mute. Thank you, Todd. We want to be respectful of your time. We have a few more questions that we can forward to you afterwards. So thank you everyone for attending. We will have the recording posted by this evening if you want to, so please share. And thank you very much for attending. Please join our newsletter at remissionbiome.org, and you can stay posted on all of our events. We have an amazing lineup coming up as well. Thank you, everyone. Bye-bye.